Sorry everyone, technical difficulties here. So we are going to go ahead and get started with the Q&A session. I'm going to have the panelists all identify themselves so you guys know who you're talking to for those that haven't spoken yet this morning, including myself. And I just want to remind everybody, we can't offer you personal medical advice today, unfortunately. So if we can try to keep our questions general, the specialists up on the panel can try to answer them to the best of their abilities. And I also wanted to thank all of you for coming today. There's a scientific conference happening across the street right now, and all these physicians and researchers have taken time out of their schedule to be here with us. So thank you, everyone. So then Camilla will be So Camilla, here in the white dress, she'll be walking around with the microphone. If you have questions, just raise your hand. We will try to get around to everybody once, so if we can try to limit to one question for the first round, and then we'll see how much time we have as we go. So, that.
Okay, who's my first question?
Oh, wait, sorry, I was going to introduce the panel. And so I'll, from here, get started. Is this on? Yeah. Okay. So, as I said, I'm Katie. I work for the Foundation for Sarcoidosis Research. I'm the Associate Director of Strategic Partnerships. So I work with all of our external stakeholders, which means pharmaceutical companies, the government, the insurance agencies, everybody that has a foot in this disease to try and get some new and better answers for our patients.
Hi, I'm Divya Patel. I'm from the University of Florida. I'm a pulmonologist, and my special clinical and research interest is sarcoidosis.
Hi, my name is Matt Zipsey. I am a cardiac electrophysiologist here at the University of Colorado. Cardiac electrophysiologists specialize in heart rhythm disorders, and there are many causes of these, but sarcoid, of course, is one.
Hello, I'm Mary Beth Sholin. I'm at the University of Utah, and I'm a pulmonologist there. And my clinical interests underlie all the interstitial lung diseases, including sarcoidosis. So thank you very much for having me here today.
You all know me. I'm Travis Miller from Medical University of South Carolina in Charleston, and I see patients with sarcoidosis and pulmonary hypertension.
And I'm Leslie Sagetku. I'm from Tulane University. I am a rheumatologist, but I have a special dedicated interest to sarcoidosis and am the director of the Center for Sarcoidosis there. And thank you for having me. This is a beautiful event.
Okay, we'll get started with our first question.
You briefly touched on small fiber neuropathy, and in what I've been reading, it just seems like it's becoming a lot more common than originally thought. I just wondered if you might be able to, if anybody had any information. I know they're looking at this ARA290 and what the prospects of that might be in treatment for small fiber neuropathy, and when the next clinical trial. I know there's upcoming where that might be, where those sites might be.
So actually, we just heard Ajani Tavi from from Cleveland Clinic speak about this compound, and it was a comparative study between the United States and the Netherlands, and the outcomes were very good, but they were not so great for those in the United States. And the issue was actually BMI or how much weight unnecessary weight we're carrying. That seems to be the signal that's different between these two groups. So, Dr. Sholin, do you have anything you want to add to that? I don't know whether there's going to be another trial. Are you guys going to do a trial?
I'm talking to Dan Culver from Cleveland Clinic. I know they're planning to do another trial with multiple centers. They haven't decided what those centers will be yet.
Okay, thank you. We've got another question over here.
I have a question. How often the rheumatological things overlap with sarcoidosis? Because it seems like a lot of times you have sarcoidosis and your tests are elevated for something else. They'll say, well, it's probably sarcoidosis, but then it's other diseases. So that to me is always kind of confusing when you see what kind of doctor do you see for that? Like,
I can actually start this one off, and then I think Leslie, I'm sure you'll want to have some input here as well. We were just joking at the grad students at the scientific conference that there is no sarcoidologist, unfortunately. So a lot of you will see rheumatologists or pulmonologists, cardiologists, depending on what your involvement may be. So unfortunately, there isn't an official specialty yet. Maybe there will be one day. But Leslie, what would you like to add to that?
So the question is really about overlapping conditions. Having sarcoidosis and having the fear of having another condition and not knowing how to tease those two scenarios apart. So if you're talking about an additional inflammatory arthritis, like rheumatoid arthritis, for example, or lupus, or psoriatic arthritis, for example, there's diagnostic criteria to help us identify those conditions. And so we'd hope that we'd be able to identify an overlapping case where somebody has sarcoidosis and another condition. And for lupus in particular, because you brought up lupus, the diagnosis is made by the potential for having some clinical signs, which is supported by serology. And oftentimes it's pretty specific serology. When I say serology, I mean blood tests. Yes. And I think it's a wise idea to see a rheumatologist. And where are you from? In Denver? Oh gosh, you've got awesome rheumatologists here. Yeah. Okay, next question.
My question is if chemicals have anything to do to cause the sarcoidosis to start. I was asked if I was around chemicals when I first was diagnosed. That's a good question.
Yeah, that's a good question. The short answer to that is we don't know. We suspect, as I said, that we suspect that there's an antigen that may be different for different people. There may be multiple antigens that are involved in the development of sarcoidosis. I know personally when I see patients that I'm diagnosing with sarcoidosis, I ask about exposures and I document those exposures. And the hope is that at some point we'll see a pattern and we'll see something that will help us to figure out if there is a cause that we can determine. But I think at this time the answer is that we really don't know. But I think most of us who treat sarcoidosis, I don't want to speak for everybody, but we do take a detailed occupational history and exposure history.
Okay, thank you. Next question.
What at this time would you say is the prognosis on longevity if you have cardiac sarcoidosis?
That's a very challenging question because cardiac sarcoidosis is unpredictable, and so we don't have a great answer to that because each individual presentation can be markedly different. What we do know is that there are many things that we can use to help answer that question. Testing, specifically, so sarcoid in the heart can cause many problems. It can cause problems with the electrical system, such that the normal beating of the heart is interrupted and a pacemaker is needed. Patients with cardiac sarcoidosis can have abnormal heart rhythms as well. Those can be relatively benign and just cause palpitations, or they can be life-threatening. So it spans the spectrum. Furthermore, cardiac sarcoid can cause the overall function or the squeezing function of the heart to be depressed. And so the presentation or the manifestations of cardiac sarcoidosis can range from asymptomatic and with everything else being normal and all the tests come back normal to severe disease. And so the prognosis is very different based on what manifestations cardiac sarcoid has in the heart. it's not. I know I didn't answer your question, but it's because a lot of times we can't tell somebody with cardiac sarcoidosis what their individual prognosis is because we don't know. It would be a total guess.
Okay, thank you. Next question.
One of the physicians talked about the tiredness. Is there anything that we can do with quality of life when tiredness is one of our medical?
That's a very good question because approximately 70% of patients with sarcoidosis experience what we call fatigue. And fatigue is a general term that can actually be divided into different types of fatigue. Mental fatigue, physical fatigue, the difficulty of arousing motivation is another type of fatigue. And one of the therapies that we found to be quite useful in sarcoidosis and decreasing fatigue is rehabilitation, physical training. And the type of physical training that happens in pulmonary rehab is a mixture of aerobic and carefully graded aerobic and resistance training to develop upper body strength and to invigorate and condition the muscles. So, and we'll actually talk more about that in my little workshop later, but this is a predominant and very disabling symptom that has a huge impact on quality of life in these patients that have sarcoidosis. Did that answer the question? We don't often, I mean, we were using other types of medications, you know, such as methylphenidate and Adderall. I try to steer away from those types of medications myself. Do you guys have any other experiences? And sometimes fatigue can remit with treatment, medical treatment of the sarcoidosis, but in some patients it persists in what we call a parasarcoidosis type of symptom, meaning if you have sarcoidosis, but then there's other symptoms going on at the same time. And we hope that if we, the gentleman who is the speaker, his name is Mr. Buckelhammer. He spoke so eloquently about the challenges of reimbursement with insurance companies. And this is a wonderful event that we have here where we bring sarcoidosis specialists together and patients together, and we can hear the needs of patients. And as a group together, we can perhaps formulate recommendations for that are in publication that can be used to get reimbursement. And we're looking at pulmonary rehabilitation and physical training as being one of those reimbursable therapies.
Okay, thank you. Next question. Yes, this kind of goes back to when somebody was talking about the rheumatologic diseases when you're diagnosed with sarcoid, and then all of a sudden you're diagnosed with lupus and then Sjogren's syndrome. Like, what happens to your body, I guess, when that happens? Is something triggered? Is that normal? Obviously, maybe not. But can you kind of touch on that a little bit?
So to clarify, so I understand what the question is, having these symptoms that lead to other diagnoses, right? But your real underlying diagnosis is sarcoidosis. Did I get that right?
Yes, and then like I was diagnosed with sarcoidosis, and then a year later I was diagnosed with lupus and Sjogren's syndrome, and then my body just like went to shit.
So that's kind of a tough question. We think that, well, there's some good fortune in that situation, in that the medications that we use to treat sarcoidosis are paralleled with that we use to treat connective tissue diseases such as lupus, such as Sjogren's syndrome. So the systemic treatment of those diseases. But again, in all of these conditions, there's also manifestation-specific treatments that or aids that can help. So, for example, in Sjogren's syndrome, if you experience very dry mouth, eyes, there are certain regimens for eye drops and supportive help. If you are experiencing experiencing neurologic symptoms from Sjogren's, or they can't differentiate whether your neurologic symptoms are from Sjogren's or if it's from sarcoidosis, still the treatment seems to be in parallel, although there's some punctuation about those two diseases that are different, and also some distributive patterns. And then it gets tough, and I think it's perhaps tough even for a neurologist. And so in those cases, if you live somewhere close to, for example, UCSF or Cleveland Clinic, you can see somebody who specializes in neurologic sarcoidosis to help to try to differentiate. Is that answering your question, sort of, kind of, or not?
Yes, it is. Thank you. Okay, thank you. We're going to move on to the next question.
Hi, what role does pain management play in the treatment of chronic pain and sarcoidosis?
Well, I think it plays an important role. The way that I usually approach chronic pain with my patients is there's two things that I ask them to do always. First is to start on a scheduled regimen of exercise or rehab. I think that's a really important part, and there's been studies that prove that that's a useful approach. And then also to make sure that there's other things that are to rule out other things that might be going on, such as sleep apnea, depression, anxiety, to treat those sorts of underlying things. And once we do that, and we rule out things like sarcoidosis affecting the joints or muscles, then usually we get chronic pain management specialists involved. At least that's how I approach it. I don't know about others on the panel.
I would agree with that exactly. And the other thing that we consider is the small fiber neuropathy component of pain. And there's very specific regimens for the small fiber neuropathy. But yes, I think it's a comprehensive evaluation for all possible causes of pain. But we take it very seriously. So I agree it's an important component of treatment.
Okay, thank you. Next question.
I wanted to ask, at what point in time or what would lead you to change off of a drug like methotrexate and then consider some of the more expensive alternatives such as Humira or Remicade?
I can handle that. So usually the reason that we treat with the immune modulating drugs is to control the inflammation. So we usually start out with prednisone to try to control the inflammation. If that's not effective, or it is effective, but we're unable to wean the prednisone down to a very low dosage, then we usually add a second agent. The cases where I had a third agent or transition to a biologic agent would be in cases where I can't control the inflammation and the resulting organ dysfunction with reasonable doses of prednisone and methotrexate. Or they have a particular manifestation that I want to treat more aggressively, oftentimes that being neurosarcoidosis or cardiac sarcoidosis. So that's usually my thought process on when to add the infusion with the infliximab or the injection with the Humira.
I'll just add one more thing. I mean, at least from the rheumatologic literature, we know that up to 40% of patients who are on methotrexate for rheumatoid arthritis don't respond to it. And Dr. Hamze at National Jewish, she's actually doing some work on methotrexate and use in sarcoidosis and for patients who respond to therapy and for patients who don't. So hopefully we'll have some more information about that in the future.
And certain drugs clearly work better for certain folks. So even though we think of infliximab as a step up or more powerful medicine because it's injected into the vein, I've had patients that have been on that who respond very poorly to it or have significant side effects. So it's not like we're saving that because it works in everybody and we're only giving it out here and there. That's not the case. We do it this way because of the way the data has shown us to do it, although the data is not perfect, as we discussed earlier. Far from it.
Okay, thank you. Next question.
There seems to be some confusing information that I've read regarding the use of vitamin D, whether it feeds sarcoidosis, but if you're also looking at treatment for osteoporosis, you're in conflict there. So I would like some additional information on vitamin D.
Okay, so I think perhaps the paradigm of feeding the sarcoidosis is perhaps not accurate, because actually what's happening is that you're actually trying to protect the body from having too much calcium, which is why we're afraid of using vitamin D, because when you take vitamin D, that's to try to increase your calcium, circulating calcium stores for bone availability. But what happens is that these granulomas, they actually are little like vitamin D factories. And that's why you've probably heard that some patients with sarcoidosis have high levels of calcium. So when you have high levels of calcium, that puts a lot of work on your kidneys to try to kick it out. And when your kidneys can't compensate anymore, they're not working, there's just the load is too much, then the calcium levels get high in the blood. And when calcium levels are high in the blood, that can cause a lot of problems to the rest of the body acutely. And in some cases, it can be life-threatening. So that's why there's a lot of care in suggesting somebody with sarcoidosis should be taking vitamin D. Did that answer that question? I hope so. Can I just add something about the fatigue question? I answered that incompletely because yes, it's a predominant symptom in sarcoidosis, but it's imperative that before you treat fatigue as a sarcoidosis-related phenomenon, that other conditions that are not sarcoid-related are looked into, such as sleep apnea, such as anemia, such as hypothyroidism, such as anemia. And those are very simple tests that the physician can do. So I just want to qualify what I said.
Okay, thank you. Next question. Is organ transplantation an option in patients that have more than one or two, maybe even three organ systems involved? Once the treatment options that have been used are not efficient or effective enough to be stable? And if so, would sarcoid be something that would reoccur in the transplanted organs?
That's an excellent question. And I think, again, the short answer is we don't know. We would consider, at least at my institution, we would consider lung transplantation in somebody with end-stage lung disease due to sarcoidosis, even if they have other manifestations of the disease in other organs. Correct me if I'm wrong, but to my knowledge, there's not a lot of data about pulmonary sarcoidosis reoccurring in patients in transplanted lung. With that being said, when people get lung transplants, they're on high doses of immune suppression. So not only are you treating to prevent rejection after a transplant, those in theory, those medications would also be helpful to control the sarcoidosis. So, again, the short answer is I don't know, but in my mind, it would not preclude a lung transplant evaluation, but the transplant physician would have to make that final assessment.
I just want to add, so there are very small studies that show that patients who receive lung transplantation or heart transplantation due to sarcoidosis, that the disease can reoccur. Again, they're very small studies, and the way that the recurrence was found was through surveillance bronchoscopy. So after transplantation, biopsies are done routinely to see if there's rejection. The important thing in all of these small studies was that the disease was never clinically significant. So what that means is that it didn't cause any trouble or problems for the patients, and likely because patients are immunosuppression, as it was just stated.
Okay, thank you.
So I just want to say one thing. I think that it's reasonable to make sure that you're seen at a transplant center and be evaluated, and do this on an individual basis, and not necessarily assume that because you have multi-organ involvement or something of that sort, or that it could recur, that would not be an option for you. So I just want to say that I would at least evaluate that option.
Okay, thank you. Next question.
Hi, I'd like to know how each of you feel about ALCAT testing or similar testing for so-called inflammatory food items, and if you feel that's a valid testing. I've been told by doctors that they feel it's too restrictive and not medical sound science, and if you agree with that, why?
I have to say that I don't know enough about that to answer that question in a really insightful way. I mean, I think that, given that we don't know the antigen for this disease, I think we all remain open-minded about what's possible, but I don't believe that the ALCAT testing at this point is to a state that we can clearly have a association or a true causative association. So I would say I remain open-minded, but not convinced that would be what I would do with the information.
There are some foods that cause inflammation in certain individuals.
I think we know that there's inflammatory diets, and there are particular risks with certain diets. We certainly understand microbiomes as being an interesting component of inflammation. But at least to my knowledge, I don't know that we're at the state that we could say X diet is clearly, beneficial in sarcoidosis. But I definitely believe that we can influence microbiomes and we can influence inflammatory states by diets. But I don't know that I could prescribe a specific diet at this point. I don't know if anyone else on the panel feels they could.
I can give you a completely non-scientific answer here. There are a lot of patients who found that anti-inflammatory diets help their disease state. That's all. It's completely a personal reaction. There's not really literature to back it up. My personal feeling is that it probably won't hurt to try, and if it works for you, great.
Okay, thank you. Next question.
My subject is pain. As is true with my doctors at Western Orthopedics here, I was wondering if you have patients who are on medical marijuana for pain. That's my question. And my comment is, I have my red card and I use it regularly, and folks, it works. Now, the letters you want are CBD.
I live in South Carolina, so that's a no for me.
I could top that with Utah. So.
I'm from Florida, and at the last election, medical marijuana was rejected. It didn't pass, so not allowed.
Oh, sorry.
Everybody's looking at me. So as a cardiac electrophysiologist, it's often not something I'm dealing with directly.
Okay.
I do have many patients who are on medical marijuana. Anecdotally, it's helped some of them. It hasn't helped others. It's not something that we endorse or prescribe at the university, but I think more data is needed.
And I can give the standard FSR answer of if it works for you, great. And that's something that I think everybody can talk about with their personal physicians and in terms of what might be your best course of treatment.
Thank you.
Camille?
Okay, thank you. Next question.
I was interested in your remarks about vitamin D. My PC has me on vitamin D. At one point, she had me on once a month, 5,000 units. And I keep telling her I was refusing calcium and vitamin D, and she said this is a low enough dose, over-the-counter vitamin D, that it won't affect the sarcoidosis. But other things she says and goes back and forth, the regular doctors don't really know too much about sarcoidosis. So am I taking too much vitamin D?
I can address that. This is something that I deal with every day in my practice. And I don't think that we have enough data to definitively say when vitamin D or calcium supplementation in patients with sarcoidosis is indicated. So I do think it varies with physician to a degree. I'll tell you personally my thoughts on it and what I do, and feel free to disagree because I know that I don't know that I'm right. So there's two forms of vitamin D that we worry about. There's 125 vitamin D, which is the metabolically active form of vitamin D, and then that gets metabolized into 25 vitamin D. And the easier test to measure, the test that most primary care doctors measure when they measure your vitamin D level, is the 25, not the 125. So when you measure, and I do this quite often, so I think I can speak pretty definitively about this, is that very often when you check a 25 level in a patient with sarcoidosis, it's low. And the reason for that is because the 125 doesn't get converted to the 25. The granulomas prevent that conversion. So if you check a 125 level, which we believe is the metabolically active form of the vitamin, it can be high. So you can have a very low 25 vitamin D level and a relatively high 125 vitamin D level. And often in that scenario that I see, I'll have my patient with a normal calcium level. If their calcium level, if the patient's calcium level is high or borderline high, then I would not consider vitamin D replacement in that patient. Where I struggle is in that patient with a normal or relatively normal 125 vitamin D level and a very, very low 25 vitamin D level. And to be honest, in patients that are older and are on steroid medication, it makes me very nervous not to give them any vitamin D supplementation. So if their calcium level is normal, I will give low-dose vitamin D supplementation similar to what your doctor did. Usually I'll do 500 international units a day or 1,000 international units every other day. I have not, when in doing that with my patients, I have not had a problem with hypercalcemia. In that group of patients I'm talking about with a very low 25 vitamin D level and a normal-ish 125 vitamin D level. With that being said, I made that up, okay? So I'm not saying I'm right. I'm saying that's what I do. I live in Charleston. I consider a very low level less than 10.
Okay, thank you. Next question.
I kind of feel that there's so many different autoimmune diseases. In fact, I know a person that has 5 of them, and you're doing across the board hit or miss on the drugs. And my question is, I'll give you a comparison how I look at it. Suppose I start throwing up constantly and I go to my doctor who gives me a medication to stop my vomiting, and that's where it ends. Doesn't look at why I'm doing it, why and if. Let me scratch that again. I'm wondering if anybody's looking into, instead of the symptoms, which I believe these autoimmune diseases are, is there anybody working on the actual autoimmune system itself to strengthen it? Because I'm sure all of these have different, what did you call that thing that connects each one of them? You can't find out why, when you have the granulomas, the thing in the middle, what is that called?
Antigen?
Yeah, they all have different antigens, right?
Well,
Each of these autoimmune diseases?
Well, no, not necessarily. We lost our rheumatologist, so you're hearing from a pulmonologist now, so take it with a grain of salt.
Which is to say, what I'm wondering is anybody doing work on the system itself, trying to strengthen it so it can just get rid of all this stuff itself?
Yeah, we literally spent the last day and a half over across the street talking about mechanisms of inflammation and how we can positively impact that in sarcoidosis, but that's looked at in all inflammatory diseases, not just rheumatologic diseases, but Crohn's disease and ulcerative colitis and other inflammatory diseases. So there's a lot of research being done trying to affect the immune system and prevent inappropriate inflammation in the body, because a lot of diseases, even septic shock, is inappropriate inflammation in the body. So if we can learn how to control that in different diseases, we're going to prevent a lot of morbidity and mortality in our patients. And a lot of work's being done to do that, but we're far away from cures in all these different diseases.
I just want to use this opportunity to plug FSR. There's, as it was just said, we're working on a lot of this pathophysiology to understand sarcoidosis, but there's so much to be done. And up until the past few years, I don't think there's been a centralizing sort of organization to get sarcoidosis doctors and researchers and even patients together. So I'll just use this as an opportunity to, consider registering on the FSR website, and your friends that have sarcoidosis, encourage them to do the same.
Thank you, Divya. And also add to, I think kind of at the root of your question was partly, we're treating the symptoms and we're not treating the disease. And we know it's frustrating, and it's, we're working to develop some new therapies that will treat the disease and that will get to the root of these problems. I shouldn't say we, they are working on this. But that's part of our role as the foundation, is to encourage new research into these early stages to figure out how we can really affect what's going on, and not just make you feel better, but actually make you better too.
Okay, thank you. Next question.
I really appreciated Dr. Rissmiller's presentation on the screening by organ. But my question is about, okay, you've been diagnosed with sarcoidosis and you have it. It manifests in one organ or another. Is there ongoing screening that we should be asking for? Because I know it doesn't spread, but I guess maybe I'm becoming paranoid in that I'm feeling symptoms about whether it's maybe it's a side effect of a drug I'm taking, withdrawal from a drug, but I'm feeling unwell. What are some standard screens? Is it the PET scan that can help me put my mind at rest that really the sarcoid is not everywhere in my body?
So I can comment on cardiac screening in patients who have known sarcoidosis not yet involving the heart. It's our recommendation that patients are screened at least annually. The screening process usually starts with the cardiac history, and we will ask patients if they've had palpitations, if they've had lightheadedness, if they've passed out or almost passed out. These are some common questions we ask. But even in patients who don't have those symptoms, we check a electrocardiogram or a rhythm strip that shows how the electricity is moving through the heart, the electrical signals that tell the heart to beat. And we check an echocardiogram, which is an ultrasound of the heart to assess how the heart muscle is squeezing. So we do that on a routine basis to catch myocardial or heart involvement when it's otherwise asymptomatic, so that we can be proactive rather than reactive in how we treat these patients. Cardiac sarcoidosis is a difficult diagnosis to make. It's the gold standard, or the way that we know patients have it, is to look at tissue under a slide. And the problem is that biopsying the heart is a very challenging thing to do, and it doesn't involve the whole heart. It's patchy, it's in small places. And so to blindly find that exact place where it is difficult. And so just because that test comes back negative doesn't mean a patient doesn't have it. So you brought up the point about PET, which is an advanced imaging technique. MRI is another one we use commonly. And so our usual screening algorithm involves the first pass of those routine tests I discussed in a history. And then if there's anything that seems abnormal, or if there's any concern, then we would move on to advanced imaging and look for cardiac sarcoidosis in that way. And so this is a process that's repeated over time and is revisited if the patient develops new symptoms.
And I think it's a good question. There are some guidelines specific to, for example, ophthalmologic sarcoid that we should screen eyes annually. We should be looking at calcium levels and liver tests and so on, and screening for pulmonary disease. But I think most of us here would say the same thing. I advise, once I tell someone they have sarcoidosis, I advise them to let me know about any symptoms that they're having that don't seem right, so that we can assess whether there's an other organ involvement. So in your situation where you're feeling symptoms somewhere, that would be something your doctor would probably want to know, and then evaluate for the possibility that sarcoid's causing it. And the use of PET scan, as a regular surveillance tool is really still in evolution. And I think we may see more of that later. But if there was a symptom specific to, that would be amenable to PET scanning to detect it, that might be something that would be considered.
Okay, thank you. Next question.
Just back to the pain management and the conflict that we all face sometimes. I was on Remicade for 3 years, and I was almost pain-free. But then after they looked at my lungs, I had more inflammation on my lungs. So do you, in your research, have you heard of, Remicade causing more cloudiness and more symptoms in the lungs? They had to pull me off the Remicade, and now I have chronic pain again. But for 3 years, I was almost pain-free, and I'm just wondering what research, or am I just an anomaly?
So there's two issues with using Remicade long-term. One thing we know about Remicade is that your body can make an antibody to the Remicade, so that over time it may not work. So that's one issue. And that may not necessarily apply to you, but the other issue is that we do know that Remicade can cause a different type of granulomatous lung disease. That's been shown in case reports in other diseases that Remicade is used. So that may be something that's potentially a reason why your lungs may have worsened. And then the third thing is the Remicade may not work for, you may have new lung involvement and the Remicade is not effective for that. I don't know if anybody else has an opinion about that.
Yeah, I agree. I agree with everything she just said. The thing I mentioned before is it's not, unfortunately, and it's a very frustrating thing for y'all, I know, and it's frustrating for us as physicians, is that one drug doesn't work for everything all the time. So you have one drug that takes care of one thing, but then it's not effective for another. So I think it's probably much more likely that your lung problem was related to the sarcoidosis rather than a granulomatous reaction to the Remicade. and it just wasn't as effective in treating that problem as it was as treating your pain. But, I'm speculating.
Okay, thank you. Next question.
I actually have a couple of questions. Are there any supplements? Oh, just one? Okay. Okay, sorry, I'll change my question. Have you found any geographical patterns for sarcoidosis?
I can start with that. There are some studies that show a higher incidence in the Southeast. As we can see from this room, there's a high incidence in Denver, I think. But that's part of what we're trying to answer with the sarcoidosis patient registry. And I'm going to be talking about that a little bit later on as well. But by telling us where you live and where you were born and things like that, we can start to call that data and find out what those patterns are. So that's an excellent reason to join the registry as well. And I'll let you guys talk about the literature.
No, I agree. It's a plug for the registry. We have incomplete knowledge. I mean, we have some reporting patterns, as mentioned, in the Southeast, and I see every year, I think at the different meetings, I see a map of where it's located. That some of that is just selection bias by, where there's centers that are treating sarcoid, who's reporting it, and so on. And so until we have a really good registry for it, I think we're going to still be left without clear knowledge of that.
Okay, thank you. Next question.
I have a question about inflammation and low-grade fever. Do you see typically in your patients running a low-grade fever? I was on a medication and my doctor took me off thinking that was the cause of it. Doesn't seem to be the case.
Again, we need our rheumatologist, but I would say that not uniformly. I don't see low-grade fevers in all of my patients who I think have inflammation. So, although we know that inflammation can cause a fever, I don't think it's a direct, I don't think we know the direct correlation, I should say. I don't know if anyone else has other experiences.
I agree. I have a handful of patients who have fevers, but not most.
I agree with that too. I do have a handful have a low-grade fever associated with their inflammation, but it's not common.
Okay, thank you. Next question.
Yes, I still have a question about the heart and the electricity of the heart and how it works, cause like far as the blood, not being able to pump, down to where it's supposed to. I have a monitor inside of my chest and, near my heart. And that's why I asked the question earlier, because he was saying it was the electricity part that was getting off in my heart. So, so I'm in this trial for 3 years with this monitor in my chest, and then I have a monitor at home by my bed, and it goes into, Vanderbilt where my heart specialists are at, where they can check and see what's going on. So I want to know a little more about that. Can you tell me that?
Absolutely. So the heart requires several components to function as it does normally. There's an electrical component, there's a plumbing component, there's the pump function, and they all work together, okay, to draw some analogies to your home. So the electrical signals are what tell the heart to beat. And the heart beats in concert, where the top chambers squeeze, we're up there, and then the bottom chambers squeeze, because there's an electrical signal that tells them to. And that signal starts at the top, at a structure we call the sinus node, and then moves down this electrical highway we're all born with, pauses at the middle, and then comes down to the bottom chambers. So as the signal moves through the chambers, they squeeze. Okay, so that's what your monitor is analyzing, is how that electrical signal is moving through the heart. What we know about sarcoidosis is that the granulomas and scar that can occur from granulomas can interrupt that electrical circuitry. Okay, and so it can mean that the signal that starts at the top doesn't get down to the bottom, and the bottom chamber then has a heart rate that's very slow, sort of a backup heart rate, 20 beats a minute, 30 beats a minute. or the scar and granulomas from the sarcoid can cause electrical short circuits, so to say, such that the heart rhythm or the heart beats erratically. So that's sort of a 30,000-foot view of how sarcoid can affect the electrical circuitry. But what we know is also that it can affect the pump function of the heart. So in other words, the squeezing function of the heart. So the signal might be getting to the bottom chamber, telling it to squeeze, but the overall strength of that squeeze is less than it once was. And that can give patients symptoms. We call that heart failure. So to give you sort of some numbers, if you're a numbers person, when the heart beats, with each heartbeat, it ejects about 50 or 60%. That's normal. And in patients with sarcoidosis, it might still be 50 or 60%. Or if there's lots of scar and granuloma, scar isn't muscle that squeezes, and so the heart function can be less than that. It can be 40%, it can be 30%. And so there are sort of multiple components to your question, I think. And sarcoid can affect all the components of the heart, and so that's why we do this comprehensive testing to look at these things.
Okay, thank you. Next question.
So my question is about sleep apnea. It seems, I've heard it mentioned several times that many sarcoid patients have sleep apnea. Is it possible that sleep apnea could be contributing to the misfunction of the immune system? Can you say anything more about that?
It's a really good question. It's a really good thought, I think, and I love for the people to weigh in, but my comments are several fold. One is that sleep apnea is a really common phenomenon in our population. We see it, the more we look, the more we find it, and as we age, it's a more prominent issue. But what we know about sleep apnea when we study the inflammatory, component of that, it is not good to be up and down with your oxygenation over the course of the night, and we see, associations with metabolic syndrome, diabetes, stroke risk, cardiovascular disease, and so on. So definitely poor sleep quality impacts inflammatory pathways. But directly associating that with sarcoid, I think that would be we need more science to tell us if that's what's happening, because it being a common disease, we see plenty of people without sarcoid that have sleep apnea. But I think it's a really good question for a study, and I think for several reasons. One, what inflammatory cascade gets set off by having sleep apnea, and is that related to sarcoid pathogenesis? We don't know. So it'd be interesting to look at that. And I think the other part of that is if treating sleep apnea impacts sarcoidosis treatment and responses. So I think your question is very good, and I think the short answer is we don't know, but I think it's a great idea.
Okay, thank you. Next question.
I have a question on prednisone usage, and just wondered if any of you have had any experience with long-term use, like 10 years or greater, without weaning off, and if once that patient weans off, if they're able to, if there's any difficulties.
I have to say, I try to get my patients off prednisone as fast as I can and get them onto steroid-sparing agents. But I also have patients in my clinic who've had sarcoidosis for 30, 40, 50 years, and they've been on low doses of prednisone for a long time, and they've done very well with it. There's always patients that come to me and I'm sure at other centers, for consultation because their doctors have tried to get them off to lower doses of prednisone, and there's just this one dose, and that below that dose, they just haven't been able to get it below that because the patient ends up having more symptoms. Most of these cases, I find that, if we get them onto medications that, what we call steroid-sparing medications, I think I've been pretty successful at that, and I think there's just a few handful that I've kept on very low doses of prednisone because they've just been on it for so many years and they haven't had any problems with it.
I agree completely with that. I do have a few patients that have refused steroid sparing agents and have been on relatively higher doses of prednisone for longer periods of time. I do have a few of those patients. And this is completely anecdotal because I don't have very many patients, and I'm happy to have other opinions. But it seems to me that with prednisone, some people tolerate prednisone very well and really don't have a lot of side effects, even though we still try to get them off the medication because of the fear of those side effects. And there's other people who have terrible, horrible side effects. So I do, to your point, I do have a handful of people who have, despite their doctor's advice, whether it was me or someone previous to me, have stayed on higher doses of prednisone and done fine and not developed a lot of side effects. I have seen that. But I think, unfortunately, that's the exception rather than the rule.
Okay, thank you. We've got one more question, another question.
I always wait till the end to listen to what everybody else has to say and what their questions are. My question is, for those of us who've tried first, second, and third line drugs, what's next?
I think you stumped the panel.
So the scientific meeting that has been alluded to, that's one of the things that we're discussing, other targets, other novel targets. And I think that we're going to come up, most of the medications that we use to treat sarcoidosis, there weren't these large studies in sarcoidosis patients. We borrowed the medications from rheumatologists, from GI doctors, and in rheumatology at least, there's this huge flood of new drugs coming on board to treat various conditions, and I think we're going to continue to keep borrowing and keep trying, and organizations such as AASOG and AASOG, this is where we sort of get together and come up with new ideas and try to work together and develop new clinical trials.
And if they're out of the box, how do you get them paid for?
Yeah, so I think that's the hardest thing. I have trouble getting Remicade, approved for my patients, and it's getting worse. That's how it feels to me.
The one, I completely agree, but the one positive thing on that is the experience that we've had in pulmonary medicine with pirfenidone and nintedanib, which are new treatments for idiopathic pulmonary fibrosis. And they're very expensive medications, brand new, effective in preventing decline, but not in restoring lung function that's been lost. But I don't know if other people's experience, but at our center, we've done fairly well with getting those drugs for our patients. So there is hope that even a new expensive drug we would be able to get for people, but there's always hurdles with insurance and pharmaceutical companies.
Yeah, and I agree with what's been said, and there was a whole session on what's next after third line, and there are, the algorithms show us the fourth line medications, some of which are available now, and some of which are in clinical trials, and again, another plug for FSR and organizations like that to galvanize and develop clinical trials together so that when we study the drug specific to sarcoid, rather than studying it in the setting of, borrowing it from another disease, then we get the FDA indication and then we get it paid for. So it's important that we say, and we need these studies and we need these trials done, and they are happening. And so one resource you could use is the clinicaltrials.gov and look and see where clinical trials are being done in sarcoid and think about getting into studies for that. And then speak up and say, hey, I want this study in Denver, or I want this in wherever you live, and these options will become available the more we speak up.
Okay, thank you. I don't know, is there anyone else I have not reached who has not asked their first question? If not, I will go on to round two. Someone in the back? Okay.
I have a friend who has sarcoidosis, and She has arrhythmias and she's been evaluated for it, but they just say, oh, don't worry. It's atrial, not ventricular. No problem at all. She has shortness of breath. I'm just wondering, should she find another doctor or is that okay?
Okay, that's okay. Loaded question. That's something that comes up. And the problem with sarcoidosis, as many of you have found out through your own medical histories, is that it's a rare disease and not every physician is as used to treating it as others. So in patients without sarcoidosis, without inflammatory systemic disease, atrial arrhythmias are something that a lot of times, or abnormal heart rhythms from the top chambers, we will treat, but are not as concerning as arrhythmias that come from the bottom chambers of the heart, which can be life-threatening. These are these short circuits that I was discussing. Patients who have sarcoidosis with cardiac involvement who are having any abnormal heart rhythm should probably prompt further evaluation. And some of those patients ultimately will receive an implanted defibrillator, which is a device that's like a pacemaker. It also has pacing function that I like to describe as your own personal paramedic. That's there all the time, just watching your heart rhythm. And if you were to develop one of these life-threatening heart rhythms that comes from the bottom chambers, then it would be there, much like a paramedic, to deliver an internal shock. Okay, and that shock would be delivered to the heart internally and break that abnormal heart rhythm, that patient back into a normal heart rhythm. So that's a big question that we all have as cardiologists and cardiac electrophysiologists: which sarcoid patients who have cardiac involvement should get a defibrillator? The question is being answered, but slowly. There have been guidelines that have been released as recently as last year, which have worked to answer that. And so just because she has atrial arrhythmias doesn't mean that she should get a defibrillator, or your friend should get a defibrillator, but it should be evaluated because it might be a possibility.
Okay, thank you. Moving on to the next question. Yes, this is for me and for everybody else in the room who has chronic pain and deals with doctors and pharmacists who give you problems. So how do we fight, I am completely sympathetic that there are people who abuse drugs. I'm completely sympathetic that there is like a national, pandemic. Like, how are we supposed to, when we comply with our, our drugs, and it's a problem. Like, how are we supposed to combat that?
Well, you're correct about the problem of prescription drugs in the United States. It's a very big problem, and more people die from prescription drug overdose than they do from illicit drug overdose. So it is a real problem in this country. That being said, I think the way most of us, I won't speak for everybody, but the way most of us do that is with help from pain experts who deal with it every day and make better decisions than I do, anyway, about how to manage chronic pain. So a lot of us enlist specialists to help us when the pain management becomes at least above my head.
Okay, thank you. Yes?
No, I agree.
And that's the problem coming out of it. It's just the SBA and the DCA are really coming down that
Well, and I can tell you, FSR, we do work with a lot of the insurance companies to try to get our patients better access to these drugs, whether they're pain drugs or the third line treatments or the off-label treatments that the insurance companies don't want to cover. That's, we do, we're in discussions with them frequently, and as well as the FDA and the NIH to try to get better access to these drugs for our patients. So it's, it's something that we're trying to work on, and it is a huge problem, and we're trying we're trying to fix it, but we're not there yet.
My question is, again, vitamin D. I was 0. My doctor can't get it back to normal. Is it normal for sarcoidosis not to have normal vitamin D? No.
Yes. I have lots of patients that despite, I told you about the regimen that I use to replace the vitamin D. If I institute that regimen and I see improvement, but they're not at a normal range, I'll sometimes accept that because I don't want to push too far to develop the problems with vitamin D metabolism that we've talked about. So I have a lot of patients who don't necessarily have difficulty with osteoporosis who have low vitamin D levels. But I accept those levels because I don't want to cause a problem by giving excess vitamin D. Does that make sense?
Okay, for time, this is going to be our last question.
If a patient with lung and cardiac sarcoidosis is monitored for the lung sarcoidosis and is stable, is there any question about, monitoring the cardiac, but is there any question about other areas that you should be concerned about? Will this get out of control in other areas just because the lung is in control?
I think this gets back to the question of screening that we touched on earlier. Just because sarcoid is controlled in one organ system doesn't necessarily mean that it can't spread, and so ongoing screening is still important. Anecdotally, I can think of patients who have been on very stable regimens of immunosuppression, but still develop cardiac involvement that then needs to be addressed. So I think the take-home message is routine screening is important. If new symptoms, if patients develop new symptoms, then prompt evaluation is needed.
I think most of us screen patients for routinely for other organ involvement, even in patients that I believe have stable disease. Normally the way I do that is with a complete blood count, CMP, which is your electrolytes, liver function, and kidney function, EKG yearly, ophthalmology visit yearly. Do those things even to look for involvement in the kidneys or the liver or the eyes, and then the EKG yearly for the heart, to look even in patients with stable disease or that are in remission from their disease.
Okay, thank you. We'd like to thank the panel for their time. I think we'll move on to the next